Now we are going to resume our master class for this morning. I request Dr. Harishankar Pathak, who is a well-known person and also ex-chairman of API West Bengal branch, and presently he is the API governing body member from the East Zone. Now I request Harishankar Pathak to introduce.
Good morning, everybody. At the outset, I thank Dr. Kumar Banerjee, Chairman of Indian College of Physicians, West Bengal Forum, to give me this responsibility to introduce our learned speaker today. Dr. Kaushik Saha is a cardiologist. He is a professor in KPC Medical College, Kolkata, and we know each other for the last number of years. Today also we have a very learned speaker, Dr. Soumitra Kumar, who is also the president of Cardiological Society of India, and he will be introduced by Professor Saha. Over to our chairman today, chairperson today, to conduct the meeting. Thank you.
Thank you everyone. Again, a good morning, everyone. Today, we are here to discuss the management of the dyslipidemia. I think thank you for giving me the chairperson post today. I think the management of dyslipidemia is very important for us in every aspect of any diseases. For example, as said by earlier, that for the cardiology purpose, it is very important because you know that every mortality and morbidity is actually depends upon if you well control the the dyslipidemia status in your clinical practice. So it is also important in the management of type 2 diabetes because you know that for the macrovascular and the microvascular complications, especially the macrovascular complication, the management of dyslipidemia is very important because for the tight control of diabetes, it does not prevent the macrovascular complications. Only the control of dyslipidemia, only the control of hypertension ultimately has got immense effect regarding the morbidity and mortality, especially the type 2 diabetic patients. So it's a very important topic for everyone. It is not only the domain of cardiology, it is a domain of everywhere in the form of internal medicine. So we are here to discuss the management of especially the important areas, that means the important parameters, newer drugs, newer things which are coming in your market. Only the statins is not the thing which we should consider in the management of the dyslipidemia. So today, as said that today the speaker is everywhere known to me as well as to the all over the faculties, Professor Soumitra Kumar. He is now the professor and HOD in the Department of Cardiology, Vivekananda Institute of Medical Sciences, Kolkata. Also, the faculty, there is a DNB cardiological program in NH Arun Tagore Institute of Kolkata, as well as the consultant in cardiology in the Fortis Hospital, Kolkata, and different fellows. I am not going into the details. There's different fellows in Cardiological Society of India, American College of Cardiology, so different areas, and also the past honorary secretary, CSI, National West Bengal branch, the past president of Indian Academy of Echocardiography, and has got immense publications over the more than 155 publications to his credit in national as well as the international journals, editor of a textbook of cardiology, different chapters, different areas, associated editors of CSI textbook of cardiology. So different areas and different things. I think it is a big chapters of Professor Soumitra Kumar. I am not going into the details. I think everybody knows him regarding the personally as well as academically. So today I will hand over my microphone to Professor Soumitra Kumar to say regarding the elaborate discussion of the dyslipidemia managements. One thing for sure, if any question is there, I think you should write down the questions in the chat box. I think after the deliberation of the speech, I think Professor Kumar will describe regarding things like different questions which are there in the chat box. Over to Dr. Soumitra Kumar.
Thank you, Professor Shah, for the kind words of introduction. Thank you, Professor Pathak, also for the kind words. And at the outset, I would like to thank the API West Bengal branch, the ICP West Bengal branch, in particular, Dr. Amol Banerjee, for the initiative and the encouragement that he has provided to me for this talk. Also, thank you, Dr. Ananda Bagchi, who is the current chairman of the API West Bengal branch, and the whole team of API West Bengal and ICB West Bengal for giving me this opportunity to address this august audience in virtual platform, but that is indeed a privilege, and that has become the custom and convention these days to in order to gain access to a larger audience. So with that introduction, my talk today is on approach to dyslipidemia. I would like to give you a broad overview, but then it is a vast subject, so excuse me if I am not covering the entire thing, but I would like to cover as much as possible. So with that, let me share my slides. Is my screen visible? Hello?
Yes, sir.
Yes, yes, yes.
Yes, sir. Yes, sir.
Okay, so approach to dyslipidemia management. I would like to start with some epidemiological data. This pertains to the overall impact on increased LDL on the incidence of ischemic heart disease and stroke globally. So here on the top, A applies to men and B to women for ischemic heart disease, and C and D apply to ischemic stroke in men and women. So you can see here that clearly the South Asian population between the years 1990 to 2019, you can see there is a increasing prevalence of ischemic heart disease that is attributable to increased LDL. And that is more so in men than women. Of course, in terms of stroke, South Asia is not the leader. As we know, it is more prevalent in the eastern part of Asia. But at least as far as ischemic heart disease is concerned, South Asia is really the zone that heads globally, and much of this risk is attributable to increased LDL cholesterol. And if we see the overall trend over the years between 1990 to 2019, you can see here in South Asia, there is an increasing trend, especially amongst men, whereas the rest of the world, it is on the decreasing trend. But in South Asia, unfortunately, it is still on the increasing side. So needless to say that we need to do a lot of things, the global risk factor control, and pertaining to today's topic, we need to lower LDL further in the vast majority of our population. Of course, fortunately for some reason, in the women, it is on the decreasing trend. And in terms of stroke, again, fortunately, it is on the decreasing trend. I mean, stroke is, I mean, maybe not because of only lipid control, but maybe because of better blood pressure control. It is fortunately that it is on the decreasing side. But what is still alarming, that particularly among men, the ischemic incidence of ischemic heart disease is still rising, which is against the global trend. So that is something that should be taken into cognizance. Now, this is a much known slide, and this gives a schematic diagram about the overall plasma lipoprotein metabolism. You can, I mean, we all know that the serum cholesterol is largely derived from the cholesterol that is synthesized in the liver, and only 15 to 20% of the serum cholesterol comes from the diet. Whereas for triglyceride, it is both from the liver and from the diet. In fact, the principal lipoprotein synthesized in the liver is VLDL, but I mean, about 50% of the serum triglyceride is derived from the diet, and it is contained in the chylomicrons, because majority of the lipoprotein in chylomicrons is like triglyceride. Now,
Describing this is going to take a lot of time. In fact, it is one of the challenges for those working in the field of molecular biology and molecular biochemistry. But I would like to tell you that the entire experimental medicine has virtually targeted all the factors here, so that standing here today, we have so many hypolipidemic drugs or drugs that alter lipid parameters in the body. So we have statins, of course, work here, HMJ-CoA reductase, and then we have targeted the PCSK9, we have targeted the MTTP, we have targeted the LCAT, we have targeted the CETP, and in fact, we have targeted the NPC1L. I'm going to talk about each one of these individually. And finally, we have in the latest times also targeted the angiopoietin-like protein 3. In fact, we have not left any stone unturned as far as lowering and altering lipoprotein parameters in the body is concerned. So, this will take an entire class to describe how these different modalities work so as to maintain the internal milieu, but it is a very complex biochemistry that is involved. Now, before I go on to tell you further about the types of dyslipidemia that we encounter, how do we level what is acceptable, what is unacceptable? Now, we say in terms of mild to moderate deviation for LDL cholesterol, in millimoles per liter, you can see, but if you multiply by 38, we get it in milligram per deciliter. 130 to 194, we say mild to moderate elevation of LDL cholesterol. For triglyceride, it is 175 to 885, and HDL on the lower side is 25 to 35. And severe deviation means LDL cholesterol more than 190. We mainly suspect some form of familial dyslipidemia in such cases. And as I'm going to show you, that most of the familial hypercholesterolemia are monogenic disorders and/or marked polygenic predisposition plus secondary factors. For triglyceride, anything more than 885 is severe hypertriglyceridemia, and HDL cholesterol less than 25 is also a severe deficiency. Now, whenever a patient of dyslipidemia comes to us, what should be our approach? We often miss out on this, but a very meticulous history taking is very important. We should get to know about the risk factors in the given patient. I'm not going to read out the entire list, but only highlight that apart from the known risk factors, we should also ask indirectly questions about the presence of CKD, NAFLD, or any autoimmune or inflammatory disease that the patient may be suffering from, any hepatitis C, history of pancreatitis, and the concomitant medications which alter lipids like steroids, retinoids, HIV therapy, anti-rejection medications. And family history is also very important, needless to say. Examination, apart from the routine clinical examination, one should examine all the peripheral and carotid pulses, vascular bruise, ankle brachial index whenever the facility permits. Look for the various xanthomas, lipemia retinalis, corneal arcus, xantheresma. I'm going to show you some pictures of this. Now, lab parameters, apart from the routine lipid profile, which we do, in fact, these days only fasting lipid profile is not mandatory. We can even do a non-fasting lipid profile. We should have a calculated non-HDL-C, not the indirectly derived, LDL thing, but we should have a directly measured LDL. Then we should have uric acid measurement, glycated hemoglobin, thyroid parameters, and whenever the facilities permit, or if the patient is particularly at high risk, we should also have LDL particle number assessment. APIWB is not that difficult, but it is costly. Lipoprotein lethal measurement at least once in a lifetime, because the values remain constant all through life. HSCRP, microalbuminuria. So these are the things which beyond lipid profile are mandatory for a comprehensive metabolic profile, and we should have the basic tests to to estimate the given cardiovascular risk in a patient. So ECG, and whenever the indications demand, we should have some form of stress testing, be it treadmill, chemical, or nuclear. Imaging, again, in a very high risk patient, we should do some coronary artery calcium scoring, or at least do a carotid ultrasound with carotid intermedial thickness. Now, risk calculators are galore. I mean, there are so many risk calculators, but none of them are particularly applicable to the Indian population. I'm going to suggest what I personally think is a more simplified approach. Now, this is again mentioning all that I have mentioned in the previous slide. So here you have the entire lipoprotein profile, and depending on the facility and the risk level of the patient, you should do whatever is required. But very important that you should have a comprehensive assessment of the patient as far as, first of all, lipid metabolism is concerned. Number two, you should always look for secondary causes. Now, diabetes, as Professor Shah introduced, is a very important comorbidity. Hypothyroidism, concomitant liver and renal disease, autoimmune diseases, hematological problems. Yes, there are some monogenic dyslipidemias associated with hematological and coagulation abnormalities, pancreatitis, particularly in patients with hypertriglyceridemia, and then again some forms of dyslipidemias, particularly the familiar dyslipidemias, have gastrointestinal problems as well. So whenever it is appropriate, beyond lipid profile, we should also assess these. Now, as I said, that this is the era of molecular genetics. So we have been able to define the various dyslipidemias and identify the specific gene that is involved. So that is a major breakthrough. And we have also been able to identify the pattern of inheritance, whether autosomal dominant or autosomal recessive. So this is a major breakthrough, the genomic analysis of dyslipidemia. And here you can see there are 3 or 4 major groups: monogenic hypercholesterolemia, monogenic hypocholesterolemia, then monogenic hyper alpha lipoproteinemia, and then monogenic hypertriglyceridemia. And then there are subgroups, or various divisions under each. So this should be taken into account. And whenever you suspect, I'm going to tell you how to suspect a particular monogenic dyslipidemia based on the clinical presentation in the subsequent slides. But the genetic analysis is also fortunately available these days, even in this country, although it is little expensive. So as I was saying that, we are clinicians, so we should know what are the clinical features and comorbidities that are associated with the various monogenic dyslipidemia. Now, as you know, that during our student days, we are taught about the Frederickson classification. Now, we have, it mentioned about 5 categories. Now, we have later on realized that Frederickson classification mainly refers to the polygenic disorders and not really to monogenic disorders. So we have largely discarded that kind of description and largely divided dyslipidemias into monogenic, polygenic, and those due to secondary causes. So these are the monogenic dyslipidemias and the clinical features associated with each type. Now, the constraint of time will not allow me to describe each one of these, but as you know, I'm going to, again, there is a summary slide which will tell you, what are the broad things that we'll look into. So these are again the various types, the clinical features, and the other comments that are associated with it. So clinical features, comorbidities, and comments. The list continues. It is quite an extensive list. So this is the summary. So this I will read in a little more detail because this is a comprehensive one and may be useful for us clinicians. So high cholesterol states, whenever you are looking at the skin, you look for tendon xanthomas. Now, this is particularly important because there is a lot of premature atherosclerotic cardiovascular disease resulting from this. You always auscultate for carotid bruise and femoral bruise, and you look for, in addition to tendon xanthomas, the corneal arcus and the xanthosoma. So mainly total cholesterol and LDL cholesterol are increased, and these are the genetic markers that are associated. And you have also to exclude the secondary causes producing this state, like hypothyroidism, cholestatic liver disease, and nephrotic syndrome. Now, high triglyceride states are associated with different types of xanthomas: eruptive, tuboeruptive, and xanthomas. Now, hypertriglyceridemia, we have also realized, is also associated with increased ASCVD risk, but more than that, it is associated with increased risk of pancreatitis and recurrent abdominal pain. Here we get lipemia retinalis, and in addition to increased triglyceride, we also get increased total cholesterol. And the genetic counterparts are shown here. And again, we have to exclude the secondary causes: uncontrolled diabetes, hypothyroidism, obesity, alcohol, and concomitant medications are very important. Oral contraceptive pills, retinoic acid, bile acid sequestrants, and steroids. Now, low HDL states, now the connection with low HDL and atherosclerotic cardiovascular disease is very variable. So that is an important point to be noted. And the genetic markers have been mentioned. And one of the common states that is associated with low HDL is metabolic syndrome and obesity as secondary causes. So weight reduction, exercise, and stoppage of smoking are the things that we do these days because we have largely given up trying to raise low HDL. Combined hyperlipidemia, again, needless to say, has associated increased ASCVD risk. Here, apart from LDL cholesterol, triglyceride is also increased, and majority of cases also have low HDL. And so, and in this, in fact, the combined hyperlipidemia described by Frederickson is largely polygenic. So we do not have a monogenic cause for this combined hyperlipidemia. That should be kept in mind. Lipoprotein, needless to say, is a risk multiplier and has increased ASCVD risk. And so we have, I mean, it is not a monogenic disorder. There is a lot of single nucleotide polymorphism that is involved in the causation of lipoprotein increase. And secondary causes, as I said, we are born with a level of lipoprotein, and unless there are medications which can lower lipoprotein little a, the levels are going to be more or less constant throughout life. Now, I just to make it little interesting, I thought I should include this in my presentation. So A, as you know, is xanthelasma. B is the arcus cornealis. Now C and D are the extensor tendon xanthomas. E and E is the palmar xanthomas. F is the tuberous xanthoma, and E and F are seen in hypertriglyceridemia. G is eruptive xanthoma. H is lipemia retinalis, and I is a typical orange tonsils that you see in Tangier's disease. J is showing the cloudy cornea, which is seen in A beta lipoproteinemia. K is the acanthosis, which is seen in the peripheral blood smear, and J is the atypical retinitis pigmentosa. So you have to be a really good clinician not to miss any of these findings. And once we discover any of this, we can make a suspicion that probably my patient is suffering from one of these so-called monogenic dyslipidemias, and then we can ask for the appropriate genetic testing to confirm the diagnosis. Now, it is very important not to miss out on any secondary lifestyle factors, because obesity is uniformly associated with altered lipoprotein factors. It is LDL, increased triglyceride, and low HDL caused by obesity. Physical inactivity does the same. Now, excess alcohol, mainly with increased triglyceride, and smoking causes a decrease of HDL cholesterol. Now, as far as diet is concerned, now it is mainly high trans fat and high saturated fat which causes increase in LDL cholesterol, but high carbohydrates, please note, cause increase in triglyceride and lowering of HDL cholesterol. Associated medical conditions are also not to be missed. Obstructive liver disease, hypothyroidism, nephrotic syndrome, and anorexia nervosa is associated with increased LDL cholesterol. And on the other hand, the bottom causes, all of them are associated with increased TG and HDL-C, just to name a few: metabolic syndrome and insulin resistance, which are interconnected, and so is diabetes mellitus, NAFLD, CRF, Cushing syndrome, HIV infection, SLE, and lipodystrophy. So these are all associated with increased triglyceride and decreased HDL cholesterol. So what should be the overall lifestyle recommendation? So nutrition, of course, We should focus on whole grains, legumes, vegetables and fruits. We should avoid added sugar, salt and fat, limit low fiber grains and potatoes, the white starches, fried foods, fast foods and alcohol, especially if there is high triglycerides. And we should limit calories for 5 to 10% weight reduction if overweight or obesity. Physical activity, any type of physical activity is recommended, but if you want a specific prescription, 150 to 300 minutes per week of moderate intensity or 75 to 150 minutes per week of high intensity exercise, and resistance training more than equal to 2 times per week. Sleep duration is very, very important. These days, our younger colleagues particularly sleep less at night. So 6 to 8 hours of sleep per night is very important. Mental health, again, is a modern day disease. So assessment for depression, anxiety, and substance abuse should be made. And smoking, absolutely no tobacco or nicotine related products. Now, LDL is the crux of dyslipidemia that we approach in our day-to-day practice. Why is elevated LDL cholesterol so bad? So it invades the dysfunctional vascular endothelium, causes macrophage recruitment and engulfment of the LDL cholesterol, leading to formation of foam cells, and this in turn leads to increased oxidative stress, secretion of more inflammatory cytokines, vascular smooth muscle cell proliferation, formation of plaques, decreased arterial diameter, plaque rupture, and ultimately to acute atherothrombotic vascular diseases. Now, statins. I thought there should be a summary slide of all the drugs that we use in our day-to-day practice. Now, all of these are right now not available in this country, but fortunately, majority are. All the statins are available. In fact, we have discontinued uses of some statins, but mainly atorvastatin, rosuvastatin, and to some extent pitavastatin that is still in use. And you can see the comments to what extent they lower LDL cholesterol. Now there are cholesterol absorption inhibitors like ezetimibe. Then there are bile acid sequestrants like cholestyramine and cholesevelam. Then PCSK9 monoclonal antibodies, evolocumab and alirocumab. PCSK9 small interfering RNA inclisiran, the fibrates, gemfibrozil, fenofibrate, bezafibrate. Of these, fenofibrate is the one most commonly used. The EPAs, namely icosapentaethyl and Ipanova. Now, icosapentaethyl, was used in the REDUCE-IT trial with some very good outcome reduction. So that is something I'm going to discuss a little more. And others, of which lomitapide is not available in this country, causes a remarkable LDL reduction. Nicotinic acid used to be available. Now it is available in, it's just one or two formulation in combination with statins, but not in much use after the failure of the MHI and HSP Thrive-2 trial. Bempedoic acid is a new molecule, and we are finding it to be extremely useful as an add-on on statins or when statins are not tolerated. And bempedoic acid plus ezetimibe is a very useful combination that is coming. And you see the LDL reduction can be in the tune of 50% with this combination. So that is something to be borne in mind, either in addition to statins or in some cases where high dose statins are not tolerated. So this is the overall approach to high LDL cholesterol measurement when it is more than 190 milligram per deciliter, or any or statin indicated condition is there, or ASCVD, like ASCVD or high risk primary prevention, or when LDL cholesterol is more than 130 plus intermediate risk is there. First rule out secondary causes, then do a clinical assessment to rule out monogenic causes and consider DNA testing whenever it is indicated. Then what should be the appropriate repeat role in the given patient. First of all, initiate lifestyle measures, do periodic lipid profiling after that. But then if it is exceeded, particularly in primary prevention, we should add drugs. But for secondary prevention, drug addition should be concurrent with lifestyle modification. We should not wait for lifestyle modification first, but we should start drugs in the first place. And we should try to achieve the target goal. And in addition to LDL cholesterol, we should also aim for global cardiovascular risk reduction. Now, at this juncture, if the patient also had hypertriglyceridemia, we can consider other treatments like icosapentethyl, and then we maximize the dose of tolerated statins. If that is not enough, we add ezetimibe. Then we can add PCSK9. And these days, as I said, we have the choice of giving bempedoic acid also freely to our patients. But other drugs like niacin has been discontinued. Lomitapide is not available. Evinacumab again is a very balanced drug, lowering both LDL and triglyceride, but not yet available in this country. Now, these are the statin trials. I'm not going to waste much time describing this. This is much known to you. Primary prevention studies, and very important thing to be highlighted that even in this patient with apparently a lower risk than secondary prevention group of patients, there has been a significant decrease in not only cardiovascular outcomes but also in stroke. So not only the coronary mortality has come down, the all-cause mortality reduced in a number of trials, and very importantly, stroke reduction also has taken place. Now, and we have the long-term follow-up of OSCOP study. We have learned about the legacy effect of starting statins early, and in fact, and we have seen the anti-inflammatory role of statins in the Jupiter trial. So, I mean, no person who is eligible to receive statins, and in these days there is a concept of cholesterol years. So, I mean, it is not the absolute level of cholesterol that we are treating, but it is the duration of the period which has this increased cholesterol that is important. So if you have a cholesterol level of say 130 and the person aged is 31 years or 32 years, so if we leave it untreated as per the some of the ACC/AHA guidelines till the age of 40, we are losing out on a very valuable period. So whenever we start the statins at age 40, maybe we have missed the bus and atherosclerosis is already in place. So we have to look the risk profile of a given patient, and if we think the person is eligible, so we have to start early. Of course, monitor for side effects. If side effects are not there, we should give the patient the benefit of starting statins very early in life. Secondary prevention strategies, of course, this is one of the most uncontroversial areas of the use of statins. We started in 1994 with the 4S study. Then we had A to Z. Then in the very bold AVAT trial, atorvastatin was in fact pitted against angioplasty, and there was a 36% reduction in ischemic events, and it delayed the time to first ischemic event by 36%. Now, other trials, you all know it, CARE, IDEAL, LIPID, LIPS, Miracle. Miracle and Prove It were the trials in patients with acute coronary syndrome. And here in Miracle, atorvastatin versus placebo, but in Prove It, it was atorvastatin 80 versus pravastatin 40. And there was a remarkable reduction in the composite endpoints of coronary heart disease death, MI, and revascularization, and even unstable angina was reduced. Then we also have the atherosclerosis regression trial. Mentioned here is only the reversal trial, but we also have the asteroid and Saturn studies which have shown remarkable atherosclerosis regression, not only with atorvastatin but more so with rosuvastatin high dose. TNT, now one of the anti-statin lobbies have always said that statins may be harmful if given in high dosage. So TNT tested this hypothesis, 80 milligram versus 10 milligram atorvastatin, and it was shown that 80 milligram is definitely superior without any added side effects. It caused a reduction of 22% in the composite endpoint. And both MI and stroke were reduced in the high intensity group as compared to the conventional low intensity group. Now, over the years, we have tried so many agents to, beyond statins to target the other facets of lipid management. Now, mipomarcin, it was started with a lot of hope. It is an antisense oligonucleotide, and it was developed in 2016, but largely abandoned because of adverse skin reactions and hepatotoxicity. There were a number of CETP inhibitors which were tried. Torcetrapib and evacetrapib were had neutral, I mean, either torcetrapib have increased mortality and evacetrapib had neutral effects. Anacetrapib trial, the REVEAL trial was a success. So it showed a, I mean, reduction in cardiovascular outcomes, but you know why it was discarded? That is quite regrettable. There was no obvious commercial path forward. So that is the reason a molecule as promising as anacetrapib, which not only reduce LDL cholesterol but also triglycerides mainly, and in fact also increase HDL cholesterol. So it was discarded despite all these beneficial effects and showing some positive outcomes. So this is, I think, quite a miss for us cardiologists. And then we have LPL gene therapy. Now, Glybera is the commercial name. Again, no obvious commercial path forward, so it was discarded. And Pradigastat, again, a DGAT, that is diacylglycerol acyl transferase inhibitor, developed in 2017 but discarded because of GI side effects. Now, there are several emerging treatments which are very promising, like Ivanocumab, as it was tried in the ELIPS study, mainly to find out how much of LDL cholesterol and triglyceride cholesterol reduction it produces. It is a versatile agent, reduces LDL cholesterol by 30 to 50% and triglyceride by 25 to 45%. Another Vupanorsen is another promising agent at LDL reduction in familial hypercholesterolemia homozygous and triglyceride reduction also. So that is another promising agent. So this angiopoietin-like protein 3 inhibitors are a promising group of molecules coming to the market. Then volanesoren, this is another promising agent which causes triglyceride reduction in the tune of 50 to 70%, and it is eagerly awaited. Then anti-lipoprotein A lowering agents. So lipoprotein A has been one of the bastions we have not been able to conquer. We have no need to be risk multiplier, but we have only targeted intense LDL lowering to counter the effect of increased lipoprotein little a. But in maybe in very soon we will be having agents. I don't know about the cost factor, but there at least will be agents which can target LPA reduction like olpasiran and pelacarsen, and they can reduce LP-little-a in the tune of 50% to 70%. And gemcitabine is another agent which causes LDL cholesterol reduction, so it can also be an add-on drug. But now that we have bempedoic acid, I don't see much of a future for gemcitabine because it causes LDL lowering to the same extent as bempedoic acid. Now, I was telling you about the use of various risk engine estimators. None of these are applicable to us Indians. So it is not very advisable that we use one of them. And also, to be very practical, it is not often possible in our busy clinical practice. So what should be an easier approach? I like this approach of American Association of Clinical Endocrinologists. They have divided into 5 categories: extreme risk, very high risk, moderate risk, and low risk. So risk factors and 10-year risk they have calculated. But mind you, if the patient is young enough, just a 10-year risk calculation may not be enough. You have to estimate the lifetime risk. Now, extreme risk, you know who are the patients. So it is much known to you: progressive ASCVD, including unstable angina, established clinical ASCVD plus diabetes or CKD, or more than equal to 3 risk factors, or heterozygous familial hypercholesterolemia. History of premature ASCVD less than 55 years for males and less than 65 years for females. Now, likewise, we have lesser category of risk patients, and you look at the treatment goals for each category. So extreme risk, less LDL cholesterol target should be less than 55, non-HDL less than 80, ApoB less than 70, and triglyceride less than 50. And accordingly, we have to be less aggressive in the lower risk categories, but very high risk, it should be less than 70, and high risk less than 100. But does this apply to us Indians? We have some concrete answer from this group. I am fortunate to be part of this group, and the publication is no other journal but in JAPI. So this is the latest publication from this group, and I am privileged to be part of this publication group. Lipid Association of India Expert Consensus Statement on Management of Dyslipidemia in Indians, 2020 Part 3. And they are also making international noise. So this is a publication in Journal of Clinical Lipidology, proposed LDL cholesterol goals for secondary prevention and familial hypercholesterolemia in India, with focus on PCSK9 inhibitor monoclonal antibodies, expert consensus, again from the same group, that is LIE. So they have identified the very high risk group. Extreme risk group has been divided into category A and category B. Now LDL cholesterol go from very high risk group is less than 50, and who are to be included are mentioned in this category. Extreme high risk group, LDL goal less than 50 is indispensable, and LDL goal less than 30 is optional. So CAD, diabetes with target organ damage or 0 to 2 major factors, familial hypercholesterolemia, and then they have identified some additional risk factors which should be taken into account. LPDLA more than 50, coronary calcium score more than 300, extreme of a single risk factor, presence of peripheral arterial disease or history of TIA or stroke. So all these patients are extreme risk group. And who are category B? That is the highest risk group. LDL goal I shouldn't say should, it must be below 30 milligram per deciliter as per the recommendation of LIE. CAD with more than equal to one of the following: diabetes plus polyvascular disease, or more than equal to 3 major ASCVD risk factors and or target organ damage. Recurrent ACS within 12 months, please note, despite on LDL cholesterol goal. So if you are having recurrent ACS, you are despite being on high intensity statin, and even if your statin is, LDL goal is, LDL target value is less than 55, if you are still having recurrent ACS, your LDL goal must be even lower, that is less than 30. And homozygous familial hypercholesterolemia LDL goal should be less than 30, but we should admit that it is at times difficult to achieve. So this is the kind of algorithm they have provided for the 3 risk groups: very high risk group, extreme risk group A and B. So ezetimibe, PCSK9 inhibitors are to be added very liberally to high intensity statin as and when recommended. And now we can add bempedoic acid also to this list. So here, how to treat LDL to goal. These are the various approaches for the various risk groups, and mentioned at the bottom are the statins, the high intensity statins, the moderate intensity statins, ezetimibe, PCSK9 inhibitor, colesevelam, and bempedoic acid. Now, one of the tragic points about high intensity statin, that we have been using them in trials in the highest dosage most of the times, but when it comes to secondary prevention, there is a very high residual risk. Even in primary prevention, all the trials have shown there is a significant residual risk. So for that, we need to do something beyond LDL cholesterol, and I will now mainly focus on that. So these, I've already mentioned about the drug. This diagram shows what are the targets: the angiopoietin-like protein 3, PCSK9, the blocking the PCSK9 enhances LDL receptor recycling, thereby reducing serum cholesterol levels. Bempedoic acid acts at the ATP citrate lyase level. And then we have the other LXR agonists also being targeted these days. And again, this goes on to see inhibiting ApoC3 and ApoB100 with these 2 new agents, as I mentioned, mipomarsen and volanerosen, and then lomitapide. So these are the other agents that are being tried. And this is a summary slide showing the status of these various agents. So you can see here only the first ones are both European Medical Agency and FDA approved, that is PCSK9, bempedoic, and inclisiran. LXR not yet, agonists are not yet approved. PPAR agonists, again not yet approved, but angiopoietin like protein 3 should be there in the market. soon even in India because they are already EMA and FDA approved, mainly Evinacumab. Mipomarsen, not approved in Europe, but approved in FDA. Lomintapide, again approved by both EMA and FDA. And Volanesoren, Nesorensen, that it is approved in EMA, but by EMA, but not by FDA. Now, little details about the various agents that we use. Ezetimibe is a versatile agent available in the Indian market for a long time, but its value has never been appreciated. I'm sorry to say, only of late, combinations of statins, particularly rosuvastatin 20 and ezetimibe has come to the market. I believe that rosuvastatin 40 and ezetimibe combination should also come. Now, it is a cholesterol absorption inhibitor, as you all know, the Niemann-Pick C1 like protein inhibitor, and it causes 16 to 24% additional reduction on top of high dose statin, and overall the absolute risk reduction is quite impressive for primary events, 2%. So these are the major trials. SANS, ENHANCE, Arbiter. SANS was a successful trial, but ENHANCE and Arbiter 6 was not. Then Victor trial was somewhat a successful trial. Pravastatin, simvastatin, or simvastatin plus ezetimibe. So there was significant reduction in CIMT in all the three groups. Sharp in CKD patients, again, combination of simvastatin, ezetimibe was successful. CEASE trial in aortic stenosis, not a success, but major success of ezetimibe came in the IMPROVE IT trial, where in post-ACS patients, it was randomized to simvastatin, ezetimibe 40 by 10 versus simvastatin 40 milligram alone, and simvastatin ezetimibe combination was superior to simvastatin alone, and the p-value was quite significant. So this is a summary of the various trials, and they have been arranged in in the terms of the sample size, and which was maximum for IMPROVE IT and minimum for Victor trials. And these are some of the benefits which we have seen in the IMPROVE IT: reduction in overall primary endpoint, reduction in non-fatal MI, ischemic stroke, coronary revascularization, and overall CV death, MI, and stroke composite endpoint. But there was no difference in cardiovascular mortality alone and unstable angina. So here you see, if you treat 100 patients for 10 years, these are the events that are halted by statin ezetimibe combination. So quite impressive. So 11 events are overall stopped if you use this combination. And the higher the risk category of the patient, higher is the benefit, and lower is the number needed to treat. So here at the bottom, you look at the number of biomarkers that are elevated, and the absolute risk difference is higher. So I said overall risk reduction is 2%, but in the highest risk, it is minus 7.3%. Please remember this. Now the role of PCSK9, I have already said how they act. Now they are produced by the Golgi apparatus, and then they cause intracellular LDL receptor degradation. If you inhibit it, there is increased LDL receptor recycling. So there is more absorption of LDL cholesterol from the circulation, leading to a significant LDL cholesterol reduction. So this is the effect of a PCSK9 action on the various lipid parameters, not only LDL cholesterol and total cholesterol, but also non-HDL cholesterol and ApoB are significantly reduced with the use of PCSK9. These are some of the trials of PCSK9. You know about them, the Odyssey outcomes trials. There was a significant decrease in the composite MI of CHD, non-fatal MI, fatal or non-fatal ischemic stroke, and unstable angina. Fourier, the Odyssey outcome was with alirocumab. Fourier was with evolocumab. But again, it produced a similar benefit as in the Odyssey outcome trials. So recently there has been some questions raised by the BMJ Open Journal, but that has been largely refuted by the TIMI working group. Now SPIRE 1 and 2 used bocosuzumab, but then despite the initial significant benefits seen particularly in the SPIRE 2 trial, it was withdrawn from the market because the good effect did not last long because of rapid development of anti-drug antibody. Now, lower the better is one kind of aphorism we always use. So why is it so? Because you see, if the LDL cholesterol is less than 20, the hazard reduction hazard ratio is the lowest, 0.76. So the risk reduction in the tune of 24%. 20 to 49, 15%, 50 to 69, 6%, and 70 to 99, only 3%. So this is some data from Fourier trial, and this is to be remembered again. So what are the recommendations by the major bodies with regard to PCSK9? So 2019 ESC-EAS and 2018 SCCH are more or less the same. So you know, secondary prevention documented ASCVD, unequal imaging findings of ASCVD on coronary angiogram or CT angiography or carotid ultrasound. And if for even after using maximum statin dosage and ezetimibe, we cannot reach the target LDL reduction of more than 50% or to a value less than 55, we have a place to use PCSK9 in secondary prevention. Primary prevention mainly with familial hypercholesterolemia or the diabetes with target organ damage or at least 3 major risk factors, or early onset of type 1 diabetes of long duration, more than 20 years. We have a place to use PCSK9. Severe CKD, EGFR less than 30, and calculated score risk of more than 10% for 10-year risk for fatal CVD. If target LDL cholesterol of more than 50% or target LDL less than 55 not achieved on maximally tolerated dose of statins. Now, but there are several pros and cons of using PCSK9. The pros are its huge efficacy and favorable tolerability. Adherence because of the price cost is a problem. And in Europe particularly, and also possibly USA, there is a prior authorization and approval that is required. But in our country, it is not so. But the major problem is the cost. Now, inclisiran is in the offing. It should be there by the end of this year, what we hear. The Orion 4 is the outcome trial, which is awaited. But as of now, we have its benefits in terms of lipid lowering. The major advantage, it has to be given only twice a year. So some kind of a vaccine that we use for lipid lowering only twice a year, injections. And Orion 9 use heterozygous familial hypercholesterolemia patients mainly. And Orion 10 used, the patient population was history of ASCVD and those who had serum LDL more than 70 with the use of statins. Orion 11, again, patients with established ASCVD or high-risk Framingham score of more than 20%. And again, LDL cholesterol, even after the maximum tolerated dose of 70 were chosen. So these are the major trials. And the overall outcomes were that efficacy favorable. We had a decrease in PCSK9 levels by 80%, a decrease almost. Mean LDL cholesterol decreased by 50% at day 510. And safety profile is quite acceptable. So similar safety profile between inclisiran and placebo. Modest excess of self-limited mild to moderate local site injection site problems and some mild increase in bronchitis, but no difference in major liver, muscle, or hematological parameters. So it is a safe drug, twice a year dosing. I don't know what the price is going to be, but if it is acceptable and affordable by most of the patients, it is a welcome addition. Bempedoic acid, as I said, is a new kid on the block, and it is a pro-drug. The active metabolite is bempedoic coenzyme A, and it requires an enzyme called ACVL1 in the liver, which is not present in the skeletal muscles. So that inhibits the ATP citrate lyase, a step ahead of the HMJ-CoA reductase, and it also inhibits the O2 enzyme, whereby there is a mild increase in uric acid and creatinine, but most of the time it is clinically unimportant. So these are the trials of patients, trials of bempedoic acid. Patients on maximum statin, maximum doses of maximum tolerated doses of statin have been tried in TR Harmony and TR Wisdom, and very low or no statin therapy, mainly because of intolerance, have also been targeted with bempedoic acid in Clear Serenity and Clear Tranquility trials. So here you see significant lowering of LDL cholesterol, 16%, 15 to 16% in patients on statins. Patients not on statins have a higher reduction of LDL cholesterol in the tune of 23%. And there is reduction in other lipid parameters also, the non-HDL-C, total cholesterol, and ApoB very importantly. And even more importantly, there is a significant reduction in HSCRP level across all the trials. You see in the tune of starting from 18% up to 32%. So it also targets inflammation. So we are all hoping that clear outcomes trial, which is expected to be presented in the ACC coming up next month, should be a positive trial. So we can use it mainly with statins whenever we are not being able to reach the target dosage. But even in patients who cannot tolerate statins, there is an option now. And as I said, bempedoic plus ezetimibe combination can reduce LDL cholesterol in the tune of 50%. But we have to be cautious. Patients over 60 years of age taking corticosteroids or fluoroquinolones with renal failure and history of tendon rupture should not be given. Avoid giving it with simvastatin more than 20 and pravastatin more than 40. Anyway, we are not using these statins anymore, not in pregnant patients and those breastfeeding mothers. Now, lipoprotein little a has been a difficult stumbling block for us. And as you know, lipoprotein little a, what is it? It is actually composed of one molecule of LDL particle containing of ApoB 100 and one molecule of a large, highly polymorphic lipoprotein named ApoA. And a characteristic feature of ApoA is that is the presence of loop-like structures called kringles. This Ki means kringles. So this is the structure of lipoprotein little a. Now, till date, we should measure LPA in the following settings: family history of premature ASCVD and increased LPA little a. All patients with premature or recurrent ASCVD despite LDL cholesterol lowering. Treatment of patients with elevated lipoprotein little a. Till date, we do not have any positive drug. So intensive lowering of LDL cholesterol has been our mainstay. Of course, those receiving PCSK9 can have a significant reduction of LDL little a. High dose niacin no longer available, no longer recommended. And estrogen has shown to be effective, and to some extent aspirin. I don't know how much reduction is. In very high levels of LPA, apheresis is one option. But fortunately for us, as I said, the new drugs are coming. Inclisiran also lowers LPA to a significant extent, and specific drugs like olpasiran and pelacarsen are coming, and we are hopeful that they should be available at an affordable price when they come. Triglycerides are a very difficult condition. In majority of the cases, it is secondary. So all these conditions have to be ruled out, and diet and lifestyle play a major factor in the control of hypertriglyceridemia. So all these drugs cause increase in triglycerides. So this is an extensive list. I'm not going into the details, but whenever you can refer to this chart in the net to find out whether the patient is receiving any drug which is causing their rise in triglyceride in the given patient. Now, these are the four types of patients with hypertriglyceridemia we face. Adults with ASCVD and fasting TG more than 150 and non-fasting more than 175, but less than 500. Adults with diabetes mellitus more than 40 years, no ASCVD, and fasting or non-fasting TG again in the same level. Adults aged more than 20 years with no ASCVD or diabetes, but fasting glucose more than 150 and non-fasting more than 175, but TG less than 500. And adults aged more than 20 years with TG more than 500 milligram per deciliter. So first of all, as I said, diet and lifestyle plays a very important role, which I have already discussed. And in fact, reduction of triglyceride on an average with weight loss is 10 to 20%, but in some patients, it can be even up to 70%. Dietary modification, in fact, is extremely important, and total abstinence from alcohol can reduce triglycerides up to more than 70%, and physical activity and exercise up to 30%. So you can easily appreciate that how important lifestyle modification in hypertriglyceridemia is. So the first category, adults with ASCVD. Now LDL lowering remains our crux, but those already with LDL less than 70, after we have ruled out secondary causes and optimized lifestyle, we may consider icosapentaethyl. So this is the overall approach for these patients. If the statin, I mean, the targets is less or more than 70, of course, we have to increase the dose of statin. So I did not mention that. Now, patients with type 2 diabetes, again, persistent hypertriglyceridemia, 150 to 499, age less than 50 or more than 50 with no additional ACVD risk enhancing factors, we continue the LDL cholesterol risk-based approach. But if patient more than 50 years with one or more ACVD high-risk features, we share decision-making patient preferences, discuss it with the patient, and again may consider icosapentaethyl, but unfortunately not available in this country. Now, more than 20 years, a patient, no ACVD, no type 2 diabetes. I mean, this is a problem for us clinicians. What should we do? Now, low ACVD risk, I mean, just diet and lifestyle. Intermediate risk, now it is a shared decision with the patient, and we consider initiation or intensification of statin therapy only. But ACVD is more than 20%. Here, we not only have to intensify statin therapy, but I mean, we should discuss the patient with the patient whether we should do something more or not. Now, these are the risk enhancing factors I thought I should discuss, because whenever we are looking at the patient, it is just not the lipid profile, but all these risk factors should be borne in mind. And one single sentence I would like to say, that by our ethnicity, by our South Asian ancestry, we automatically fall in the ACVD risk enhancer category. So that is something to be borne in mind. And also look at HSCRP, Lp(a), ApoB levels, and ankle brachial index. Now, this is again a very critical category of patients, TG 500 to 999 and TG more than 1000. Now, adults aged 20 to 39 or aged 40 to 75 with TG in this level, 500 to 999, or 10-year ACVD is less than 5%, or with TG in this range without ACVD or DM. If the hyper TG triglyceridemia is persistent, not only diet and lifestyle, we have to consider a fibrate or prescription of omega-3 fatty acid, namely again icosapentaethyl or omega-3 fatty acid ethyl esters. And on the other hand, patients who have this range of triglyceridemia, 500 to 999, but the 10-year ACVD risk is more than 5%. Here we have to initiate and increase the statin therapy, and again we have to consider fibrates or omega-3 fatty acids. But if the TG is more than 1000, we have to wait for nothing. We have to give fibrates or omega-3 fatty acid, whichever is affordable and whichever is available. Okay, so this is a summary of all the drugs I have mentioned in the conversation. Not mentioned. So the point is that we have embarked on combination therapy even in dyslipidemia. So not only in diabetes, not only in hypertension, but also in dyslipidemia, we have an array of drugs. And as you can see, a combination of high-dose statin, bempedoic acid, and ezetimibe can lower LDL cholesterol in the tune of 75%. So what if our patients cannot afford PCSK9? Now we have these three drugs which can lower LDL cholesterol in the tune of 75%. So that is something to be borne in mind, and we can tackle not only patients of high risk ACVD, but also patients of familial hypercholesterolemia. So this is the modern approach of dyslipidemia, which I mentioned, and I will not go into the details anymore. So this is a summary, but just before I conclude, some essential points. So we should first approach the classification. What am I dealing with? Primarily hypercholesterolemia, hypertriglyceridemia, or combined dyslipidemia. We can do in selected patients ApoB and Lp(a) assessment, genetic testing whenever on clinical parameters or on history taking we suspect a monogenic dyslipidemia. Now hypercholesterolemia from LDL cholesterol is managed basically using statins and adding ezetimibe and PCSK9 antibodies whenever they are indicated. Inclisiran, bempedoic acid, and evenocumab are poised to fill unmet clinical needs. Intervention to prevent ACVD in hypertriglyceridemia is currently limited to icosapentethyl. Severely elevated TG levels can be reduced by fibrates to prevent pancreatitis. New agents targeting ApoC3 mRNA will also be helpful for patients in coming future. Antisense agents and monoclonal antibodies targeting angiopoietin like protein 3 can correct several hyperlipidemias, both LDL and triglyceride. Utility of antisense agents targeting Lp(a) will depend on cardiovascular outcome trials, ruling out secondary factors, encouraging a prudent diet, exercise, weight loss, along with global risk factor control remains the cornerstone of dyslipidemia management. Thank you for your very patient hearing, and I'll be happy to answer any questions.
Thank you, Professor Kumar, for elaborate descriptions of the management of dyslipidemia. I think you have touched everywhere. That means from the classifications as well as the different class of drugs which ultimately targeted to which areas, different complications of dyslipidemia like high LDL or low HDL or combination of high LDL as well as the triglyceride level, individually isolated triglyceride levels. So there are different class of drugs and different areas. You have touched everything as usual. You have done always. There are good things for us also because it's a very difficult task to decide where we should start these drugs because generally what happens, we usually start the statins as far as the treatment of dyslipidemia is concerned. But there are different aspects regarding the specific areas of the management of dyslipidemia. I think there are different questions are there in the chat box. Before starting their questions, I think 2 or 3 questions from my end. As you have said that the Lp(a) and the ApoB are very important. So my question is that where we should do the ApoB as well as Lp(a) in our clinical practice because it is a consume some amount of cost apart from doing the lipid profile and how frequent we should do these ApoB as well as the Lp(a) because you know that ApoB is a far more important markers rather than have a the cardiovascular complications and all these things apart from the non-HDL levels. So this is the first questions. And the second question is that where in our practical scenario, because you know that we are using day-to-day the statins. As you have said that ezetimibe is very unrecognized areas because we are not at all, we are using the ezetimibe just few months back or few years back. Nowadays, there are some combinations with the rosuvastatins and all these things. So we are now doing or now prescribing the ezetimibe in our clinical practice. So how frequent we should combine this ezetimibe in our clinical practice and where we should use ezetimibe as combined with the statin? These are my 2 questions.
Thank you, Professor Shah. So, I mean, first question that when we should measure ApoB and Lp(a). Now, the advantage with Lp(a), you have to do it once in a lifetime. So, whenever there is a significant family history of premature CAD in particular, and those patients who present to us with established ASCVD at a young age, those are the patients we should invariably do Lp(a) at least once in a lifetime, so that right now we cannot do much for those patients except using PCSK9, but that cannot be afforded by majority of the patients. But at least we should make the patient aware that there is some uncorrected risk factor in you. Whatever we can do to lower your LDL cholesterol to the lowest level, we should do. So those are the patients who should be treated with statins and probably ezetimibe and bempedoic acid to bring down LDL to the lowest level. So that is Lp(a). ApoB, yes, ApoB measurement is not static. I mean, we have to remeasure it after we initiate the therapy. I mean, ApoB can be modified not only by bempedoic acid but also by the established drugs that we have. But the only problem is that it is a very expensive test, and the poor man's surrogate is a non-HDL cholesterol, which is much easier to calculate. So my general practice is just to look at the non-HDL cholesterol. I do not quite frequently do APOB, but again, those patients who present very prematurely, or those who are having recurrent events, like you are giving the maximum lipid therapy, but patient again has a recurrent event and is compliant. We know that the patient is compliant, but why is the patient having a recurrent event? And only for those limited patients I assess the APOB. Regarding the second part of the question, ezetimibe. Ezetimibe I mean, the overall recommendation would be go to the maximum dose of the statin. And if we cannot reach the LDL target, despite that, we should add ezetimibe as the first add-on drug. But in many cases, patients may not tolerate such high doses of statin, especially in CKD. I mean, since chronic kidney disease is a very prevalent problem, so when most of the statins, particularly rosuvastatin, is not recommended in high dosage in CKD patients. And atorvastatin also, we often cannot give in the highest dosage in such patients. Adding ezetimibe in such patients is often very useful. And other patients also who are reluctant to take or may not tolerate high dose of statin, as in ezetimibe, even to 10 to 20 milligram of rosuvastatin is recommended. I can see, I mean, a lot of patients are tolerating that combination fairly well. But overall recommendation would be to add it after you have reached the maximum dose of tolerated statin.
Thank you. Excellent. So can I take the questions from the chat box? The
Yes.
first question is that what is the standard method of LPA measurement? Yeah.
That is something that should be addressed to the biochemists, but
Yes.
I mean, I'm not the appropriate person. I know there are variations from lab to lab, but if you, it is a standardized method now. There are methodologies laid out by both the WHO and the global recommendation bodies. So you have to talk to the pathologist or biochemist concerned about the method that they are using.
Yes,
So
generally what happens, we usually do the test, and I think more than 30 we will consider there is a problematic
yeah,
area.
more than
So
30 is abnormal and more than 50 is alarming. I
50
mean,
is
more than
alarming.
50
So
that's
just as you have said earlier, we just alert the patient that you have a high ASCVD
uncorrected
criteria.
factor.
So you have to do the lifestyle modification, and you have to stick to the high intensity statins as far as possible. Don't stop the medications, as we have seen that if you giving the medications like antihypertensive, like oral diabetic drugs, they generally tend to stop the statins fast because they think it is a add-on drug. But we have to motivate that patient that you have got the ASCVD score high because you have a high LP little a. So that is the significance of doing the LP little a. So next question is that vitamin D deficiency, 12 deficiency, and the vegan atherosclerosis.
Yeah, the vegan atherosclerosis doesn't come as a surprise to me, because as I said that in fact most of the LDL cholesterol comes from the samosas and the other things that we
Yes.
have as fast food. Okay, so trans fats. So being a vegan, I mean, not taking meat and other things is not an advantage. And most of the LDL cholesterol is synthesized in the liver. So vegans are not protected against atherosclerosis. That is the first message to be conveyed. And B12 deficiency comes, I mean, it's more prevalent amongst the vegetarian population because B12 is mainly contained in the animal protein. So, I mean, that is associated with the vegetarian habit. So, I mean, vegetarians always tend to think that I'm not taking any non-veg stuff, the meats, and in fact, fishes are good. That is something to be highlighted. So,
Yes.
fish oil is good, and I mean, there is no bar in taking the oily fishes. So, there is nothing grossly wrong with non-vegetarian habits. Anyway, it is left to the individual. Even if it is a vegetarian, he is not immune to atherosclerosis. That is the message that is to be conveyed. The next
So
question
the answer
is
to this question, yes. Answer to
Yeah.
this question is that in spite of having all these things, we have to follow the guidelines. It is not
Yes,
that
definitely.
we are
I mean,
vegan or vitamin D deficiency is all these things.
Yeah,
So
when I
next
said
question
that,
is,
I mean, LDL cholesterol is not so dependent on diet. It is trans
yes.
fats and highly unsaturated, I mean, highly saturated fats, if the intake is high, that alters LDL levels. But overall, diet is more intimately associated with triglycerides. And vegetarians, unfortunately, consume a lot of carbohydrates. So they have a higher incidence of both diabetes and hypertriglyceridemia. So that should be brought to their notice. So
Yes. The next question is that calcified aortic stenosis and atherosclerosis relationship.
no, I mean, we had a lot of hope that lowering statins would prevent the progression of development of degenerative calcific aortic stenosis. But the trials, as I showed, the SEAS trial with statin ezetimibe combination was a failure. So we now know that that is a different mechanism. I mean, a lot of people are pinning their hopes on lipoprotein A lowering and prevention of degeneration. I don't know what the outcome will be, but as of now, that is a different disease, and I mean, we should lower LDL cholesterol for prevention of MIs and strokes and other ASCVDs. But calcific aortic stenosis retardation of progression with use of statins so far has been a failure.
Okay. I think you have given the answer to the next question. I had already given the level of triglyceride to start the treatment. I am not going into the details
I have
because
specified the groups.
specified the groups. So that is also answered. And the next question is that myositis and the statins.
Yeah, I mean, this is, in my opinion, it is a overhyped thing
Yes.
because it is a statin and muscle. This myalgias do occur. I don't know how much is attributable to the statin or how much to lack of exercise and other things. But some myalgias do occur in patients. But if patients are properly explained that these myalgias are nothing sinister, they are not going to affect your muscles, or you are not lose power in your limb. But myocytes and myopathy is something different. You have to document in terms of the CK rise. If the CK rise is more than 5 times, in that case, you have to stop statins for 4 to 6 weeks. But if it is less than 5 times, you can change to some other statins, lower the dose of the same statin, and find out whether the patient is tolerating, and find out the concomitant conditions like, I mean, overstraining in the gyms. I mean, gymnasia is a very frequent thing. Then hypothyroidism, CKD, and concomitant use of fibrates. I mean, this is something often overlooked. So other factors have to be looked into what is causing the muscle problem. So often it is blamed on the statin only, but in my personal experience, frank myositis and statin use practically less than 1%, close to zero. So I have not encountered any problem with the patients. So, but there are friendly statins also in this regard, although not very high intensity. Pitavastatin is said to have a lesser incidence of myositis and myopathy. So we have avenues, and as you said, now we have very good alternatives. We can add a low dose statin with ezetimibe, or we can, for the time being, discard statins altogether and give a bempedoic acid and ezetimibe combination in such patients.
So there is a
Finally,
clear guideline. Yes, clear guideline. Okay, Dr. Patel, ask your questions.
I have one question and comment. We have a lot of discussion about saroglitazole. Saroglitas are everywhere. And practically, I have seen that it's a very good drug for reduction of LDL. So what is your comment, Professor Kumar?
LDL or triglyceride?
No,
triglyceride.
Triglyceride.
Yes.
Triglyceride.
Oh yes, excellent drug for triglyceride, and more or less devoid of side effects. That is a very important thing. So it is recommended.
Why it is not recommended? And nowhere there is any.
No. You see, 2 reasons. It is an Indian formulation, so not approved by the European or the American body. Number 2, there are no outcome trials. No outcome trials except in NAFLD. Okay. So it is approved for NAFLD usage, but not for use in dyslipidemia as such. But there in the DCGI is approved it for diabetic dyslipidemia, for lowering of triglycerides in particular in diabetic subjects, and it also lowers the glycated hemoglobin level, as Professor Shah probably will agree to the tune of 0.5 to 0.7%. So in diabetic
Yes.
patients in particular, it's very useful. As per guidelines, we cannot use it in non-diabetic patients. That is a limitation. But overall, I fully agree. It is a very useful drug and quite a safe drug. So
Yes,
I
I think
use it a
one
lot.
thing, one thing I can tell you in everybody that I think it is in process of getting the approval from the US FDA, because
Okay.
they file all these things for approval in the US FDA for the high triglyceride level in diabetic patients. Still
Okay.
now we have got the recommendation from Indian authorities, so we can use in our
Okay.
clinical practice, especially the diabetic patient with the high triglyceridemia. So this is a very
Okay.
good drug we are using right and left today. So this is
Okay.
not that new one. But as Professor Kumar has already said that it is a Indian molecule, so they are having a lot of restrictions for their any regulations regarding the
Okay. Okay.
their all these things.
Okay.
Next question is that lipid and vascular dementia.
Yeah, I mean, contrary to what we used to think that, I mean, most of the dementias are of Alzheimer origin, but now we have discovered that vascular dementia accounts for this vast majority of even premature dementia that we are seeing in the young patients. So, like any vascular disease elsewhere in the body, we have to target these patients very aggressively with lipid lowering therapy and global risk factor control. So nothing specific for vascular
Yes.
dementia, but definitely they are eligible for. And whatever the cognitive dysfunction that was ascribed to statins has largely been ruled out. So this in amnesia and other things, memory loss, I mean, all those are a myth now. So statins do not cause any cognitive dysfunction. So we can use statins as indicated in the given patient, even for vascular dementia.
Yes. Going to the next, before going to the next questions, I think I have one questions again. Have you said that the pitavastatin? So, what is the exact area where we can start the pitavastatin in place of any other established statins like atorvastatin and rosuvastatin? Because it is not so much of any noise polluting any of the areas. So we are not using pitavastatin in our clinical practice. There are certain areas where we should start the pitavastatin in places of atorvastatin. I think, what is your opinion?
Yes, pitavastatin is a statin which has a lot of evidence. Even if it has outcome trials to its credit, it is not recognized. It is approved by US FDA also, but it is not a high intensity statin. It is mild to moderate intensity. First, that has to be mentioned. Even it has a trial showing regression of atherosclerosis. So don't underestimate it, but it is not a high intensity statin. Two advantages. Number one, it does not cause, I mean, it is said to cause lower, I mean, it has a lower incidence of new onset diabetes, which overall with statins is 9%, but it is said to be lower with pitavastatin, and it has less of liver and muscle toxicity. So, I mean, I have put my son on pitavastatin because he has a long way to go. I don't want him to develop diabetes. So, particularly for young patients who are eligible to receive
Yes.
a statin on the basis of their lipid profile, but I would like to put them on atorva or rosuva because they may end up with diabetes later on, just statin induced. So that is one indication, and it is quite well tolerated. So people who need mild to moderate intensity statin are young enough. So I think those are the patients who are eligible for pitavastatin.
So the take-home message is that young peoples who require the low or medium dose of statins for the long periods, they can be started with pitavastatin in places of rosuvastatin or statins,
Exactly.
atorvastatins. Okay, I will take the next question. So what is the relationship between the hypothyroidism and starting of lipid-lowering agents? These are special areas.
As far as I mean, hypothyroidism is one disease which is associated with both increase in cholesterol and triglyceride. So, like in other diseases, unless the patient already has established ASCVD, if the patient does not have any established ASCVD or multiple risk factors, only isolated hypothyroidism, I would first advocate control hypothyroidism by supplements. And when you have done so, re-estimate the lipid profile And if the patient is still eligible to receive LDL lowering drugs, then put the patient on statin. So first control of hypothyroidism is indicated to find out the baseline level after control of hypothyroidism.
Yes, exactly so. Because if we in our clinical practice, we have seen that if I control the hypothyroidism status by giving the thyroid hormone replacement, then probably the LDL as well as the triglyceride level go down. But if it is not there, then you have to start the statins as far as the recommendation is concerned. So these are the chat box questions. Any questions from the panelists or any other areas? Sir,
Both
yes.
Kaushik and Soumitra, there is one question in the question answer box. Please attend that question.
Oh, one question is left. Okay. Drugs in atherosclerosis, regression of atherosclerosis. So this is the question which are left.
Yeah, and then in the question answer, definition of dyslipidemia. How to think start antilipidemic. Okay.
Where it is. Okay.
In the question answer box. Okay.
Question answer. Yeah. Definition of.
So first of all, regression of
yeah.
is a topic very close to my heart. In fact, we have seen it number of trials. As I mentioned, a few reversal, asteroid, Saturn, and then near infrared spectroscopy. We had the ELO2 trial showing that in the non-culprit arteries, if we use high intensity statin like rosuvastatin, the non-culprit artery lesions in fact underwent regression. So regression of atherosclerosis is not only a hypothesis, but it is an actual reality. We can achieve it both in terms of reduction in the atheroma volume and not only retardation of progression, but actually we can have some regression. So it is a reality, and statins usage can lead to much lesser need of revascularization in a good number of patients. So we have patients of single vessel disease who are on optimal medical therapy, put on statins, and many of my patients, even after 15-20 years, have not required any revascularization. So that is something of a reality. Definition of dyslipidemia, I said what are the cutoff levels. So you have to assess the risk of the patient. I have given you various risk status. You have to find out whether the patient is above. So the time has probably come when most adults should be on some statins. Okay, if you are not taking it, I think it is your loss. You talk to the patient. It is up to you. You may think that I am hale and hearty. Well, why should I take it? But you may be hale and hearty today, may not be tomorrow. So it's better that you are on a. You start with a low dose of statin, doesn't matter, but be on a low dose of statin.
Another question is popped up. That is, what percentage of Indian population achieves the lipid targets till now? I think these are statistical questions.
Is there a national registry? I'm not aware of it. Probably
yes.
Professor Amol Banerjee would know. I mean, Amol, is there any data?
Yes.
Of what percentage of patients from the
Actually, it is, yes, of course, this is epidemiological data. But I cannot just right now say what is actual the answer.
Yes.
Regarding
we don't have any statistics.
Of patients they have achieved the target level. So now I cannot say. One thing, with the permission of Kaushik, I like to Soumitra's comment with the very upcoming two issues regarding the risk factor, atherosclerotic vascular risk factor. One is that your LDL triglyceride. You know, there's a upcoming terminology, LDL triglyceride, and another terminology is the HDL triglyceride. Your comment, please.
You mean the as a combination LDL triglyceride?
No. I'm telling just terminology is such that LDL cholesterol by some specialized methods like MR spectroscopy, we can take out what is the triglyceride level in the cholesterol LDL molecule. This is very important since it has been done by some Copenhagen study, and it has been shown that higher the LDL triglyceride level, more the atherosclerotic vascular risk factor. The same is applicable to the, since for the beginning, I told you this is the upcoming issue or terminology. When that two terms will be used, LDL triglyceride level and HDL triglyceride level. So for theoretical purposes, these two terminologies are upcoming. So I think postgraduates and physicians should be aware of that. It has for practical purposes, by all counts, it has in our country has not much relevance since we cannot go for the EMA spectroscopy assay of the triglyceride content of LDL, but for the theoretical purposes, particularly for the postgraduates, both PGTs and PDTs, it is some relevance. These are the upcoming new terminology, particularly so far as the risk is being concerned.
Yes, I have read that Copenhagen article. It's called the remnant cholesterol.
Yeah.
So I mean, to put all together, it's a remnant cholesterol.
Yeah. Anyway, if Kaushik, you have anything to add or say, then we go for our some paraphernalia is there. We go to that.
Okay.
As a chairperson,
The thing,
you would like to say
yes,
anything more?
I think these are actually a well-planned discussions regarding the management of dyslipidemia. I think Professor Kumar, as always, is a very elaborative and crisp and to the point, and the management of dyslipidemia. I think everyone is enlightened regarding the newer areas of the management, apart from the statins, and where we should start the bempedoic acid or the ezetimibe in our clinical practice. So we are having a lot of questions regarding all these areas, the special areas like hypothyroidism, special areas like atherosclerosis, special areas like the myositis. So actually, at the end of the day, our target should be that the patient should be, as the Professor Dr. Kumar said, that should be on at least for the low dose statins. If it is not possible, then we have to increase according to the levels of both the LDL or the triglyceride to increase the dose. I think the lifespan will be more if you start the statins early. And in the young age, if possible, then we can start with pitavastatin as because it is the chances of less amount of incidence of type 2 diabetes in the later part of the life, as well as there are complications. So altogether, it's a good discussions. This is from my end. I think, said Dr. Amol said.
Excellent. Yes, thank you, Kaushik. I should say that this is an excellent review. An excellent review regarding the dyslipidemia, different aspects, including the management. He is very elaborately in a masterly way. It is a master class. He has done masterly way. He has dealt the issue in a masterly way. Now I request Dr. Supriyo Sarkar, who is our senior member, to give the vote of thanks.
Sir, whether I am audible now?
Yes.
Yes. So from the platform, virtual platform of Association Indian College of Physicians, I thank Dr. Soumitra Kumar for his nice, long and practical analysis, particularly the classification, drugs, trials, and guidelines about the dyslipidemia. I also thank Dr. Kaushik Saha for nicely conducting the session, particularly the question answer session. I thank all members of Indian College of Physicians, particularly Dr. Amol Banerjee, Dr. Satya Ganguly, Dr. R.N. Sarkar, Dr. Apurva Mukherjee, Dr. Pathak, Dr. Subhenduda, and other panelists. I cannot see all of them. And lastly, I should thank the delegates and students particularly who has attended the class and thereby make them enlightened. With this comment, I hand over the mic again to Dr. Amal Banerjee, sir.
Thank you, Supriyo. Now we are going to adjourn this master class till